Okay, hello everyone. My name is Nathan Butler from Active Health Clinic, and I've joined with Jackie today. So we might start by giving a little bit of a background on us and what we're going to do. So I'm an accredited exercise physiologist of around 20 years now, which makes me sound quite old when I say it out loud, and I probably am getting a little bit older anyway. But today we're going to talk about orthostatic intolerance, POTS, because they actually differ in conditions. Ehlers-Danlos syndrome, which is a connective tissue disorder, and also hypermobility spectrum disorders. Realistically, there is so much to talk in regard to these. So today is really the basics about sort of exercise precautions and considerations. And we'll also have some time for Q&A as well. So as I mentioned before, we love questions. We want this to be a discussion. There's nothing right or wrong. In fact, if we don't ask the question that you're thinking about, then you're probably not helping yourself or someone else that might be on today's webinar as well. So Jackie's in charge of the slides, so I'm going to let her click those. So we're located in Blackburn and Mornington in Melbourne. But we also offer a lot of telehealth sessions. So this just hasn't been through the COVID time, even though we are now nearly fully telehealth. We've been doing telehealth for the past decade, and we're fortunate enough to see people around Australia and internationally as well. So through Asia Pacific, America, and Europe, basically nearly any English-speaking countries. I tallied up, and it was before that we've all to combine probably have about 60,000 hours of direct one-on-one experience. So we're blessed to meet a lot of people, help a lot of people in their journey. We see people with these blood pressure regulation disorders such as OI and POTS, but we also see a lot of chronic fatigue syndrome, a lot of pain sensitizations, especially more fibromyalgia, and sleep disorders, so mainly the central sleep disorders like narcolepsy and idiopathic hypersomnia. And we see a lot of overlap in these conditions as well. I often say it's a little bit like the Olympic rings, that you might have a couple of the colours, maybe not all, and some people are lucky or unlucky to have all of those rings depending on which way that you look at it. So we have 10 practitioners at the moment, so combining exercise physiologists, exercise scientists, psychologists, and dietitian. By the trumpet, Jackie, we won the Exercise and Sports Science Practice of the Year 2014, which is a very nice thing. But we always like to give back and do these webinars as well.
Thanks, Nathan. I'll just do a little bit of intro of myself. So I'm Jackie. I'm one of the senior exercise physiologists at Active Health Clinic. I have also been a patient of Active Health Clinic. So back in 2008, I was actually lucky enough to come across Nathan, who assisted me when I was diagnosed with chronic fatigue syndrome. I also suffer from orthostatic intolerance and POTS, and I have a hypermobility spectrum disorder. So I am, living and continuing to learn all about these conditions, but also living with them myself. I've been with Active Health Clinic for 4.5 years now, but been living with these conditions for, well, essentially my entire life, but also knowing more about living with them over the past 13 years. And I've been an exercise physiologist for, I think, coming up 13 years now. So yeah, when I say that, sometimes it's making me feel a bit older as well. We're really excited. I mean, this is very close to my heart, having lived with these conditions, but I'm really excited to be able to deliver this information for you today.
Yeah, time flies when you're having fun, is what I say, Jackie. I think with these conditions as well, our learnings have developed so much over the years. And I'd say every single year there's so much more new information, which is really heartening, because that means that we can make more of a difference to the people that we manage and treat. Okay. So OI stands for orthostatic intolerance, and with the name orthostatic intolerance, orthostatic refers to blood pressure, and intolerance means that we're not very good at it. I think is probably one of the best ways to put it. And it's actually an umbrella term for lots of different blood pressure regulation disorders. Generally, people, their symptoms are worse when they're upright. And if you think if you're lying down, it's very easy to get blood around on like sort of a river, where if you come up like this, if you start tipping the bottle up. So anything that has a gravity, or with gravity, is going to be a little bit more of a challenge. And so orthostatic hypotension has been defined as generally a reduction of 20 milligrams of mercury in systolic blood pressure, or 10 milligrams of mercury of diastolic blood pressure within 3 minutes of standing or tilt table tests. So often these conditions are diagnosed by tilt table tests, but that is usually quite unpleasant. If anyone's had the pleasure of doing one, they're not much fun. So a lot of the specialists these days will actually just diagnose through a simple lying to standing blood pressure test and symptoms. So orthostatic symptoms: palpitations, chest pain, lightheadedness, blurred vision, shortness of breath, headaches, nausea, and fatigue. And a lot of these are directly related to the management of blood pressure. So lightheadedness and blurred vision mean when we go to an upright position, the blood moves away from our head. So the blurred vision, or tunnels, or black and white, sometimes even blindness, is actually a decreased blood flow to the optic nerve. And when we get that dizziness feeling, it's not that we are not getting enough blood to our brains. It's that, because if that was actually happening, then we'd have brain damage. It's an early warning signal from the body saying, hey, this is going to cause a problem soon, so I'd like you to do something about it. And I suppose generally that means that we don't faint, because we listen to it, we fidget, we move. Often when you see someone, if you do see someone faint, it's because they've been standing still for a long period of time. So wedding parties are usually the classic that you see on YouTube. And then you've got things like soldiers, etc. So they might be having those symptoms, and often if you look closely, they'll be wobbling a bit and then they go timber. Most people won't do that because evolution has taught us that we don't want to fall and bang our heads. So a lot of these symptoms are really around regulation of blood pressure, and we can go into great details. We will go through some more of those symptoms and what they mean, but if anyone has any questions about particular symptoms, then we'll endeavour to explain them today. So POTS pretty much stands for Postural Orthostatic Tachycardia Syndrome. Now, this one, so postural means change in position, orthostatic means blood pressure, tachycardia means fast heart rate, and syndrome is we don't know why it happens. Now, we are starting to learn a bit more about it, but it's basically a subgroup of orthostatic intolerance, and it's more to do with tachycardia than drop in blood pressure. So we look at when someone's doing that standing test, that they either have an increase of 30 beats per minute from their resting heart rate or lying down heart rate, or it's above 120 beats on standing. So POTS is an abnormality in the regulation of the heart rate. The heart itself is sound. There is no problems that come with this. Very occasionally with some extreme hypermobility, so within Ehlers-Danlos syndrome, and Jackie will talk about this a bit later, that there can be some valve problems as well. Similar in Marfan's, but that usually can be ruled out quite easily with a scan. So what happens with our blood pressure? So when we stand up, if we think about our blood vessels, they'll constrict so that we maintain our blood pressure. So that means our blood just doesn't go straight down. So when we do that, our body maintains it and we don't have any symptoms. Now, if our blood vessels don't constrict as well, often that we'll see a slight increase in heart rate, or we can see a larger increase in heart rate in POTS. Because if the pipes aren't squeezing, then the motor needs to go faster, which is the heart. So that's why we have that increase in heart rate. Now, the diagnostic criteria, so we sort of went through that a little bit before. So it's an increase in 30 beats for standing upright over a period of time. And in adolescents, it can be 40 beats as well, so up to 10 minutes. So it's really important if you're doing this test within clinic, you get someone to lie down for 5 minutes. Now, a lot of GPs, they really struggle with time to do this. And so, especially with telehealth, we'll link in with local health professionals and get this done. But it's really important that people are lying down for at least 5 minutes and to get those baseline measures. So blood pressure and heart rate. And then on standing, blood pressure and heart rate, but then standing still for 5 to 10 and even up to 10 minutes. If someone has a positive at 3 minutes or 5 minutes, you don't have to get them to keep standing there to 10 minutes because it can be quite uncomfortable for the individual. Because a lot of those symptoms are not only feeling lightheaded and dizzy, and it's not a fun thing to feel like you're going to faint, but they can also have nausea and headaches and other symptoms too. So these symptoms need to be present for at least 6 months as well. So we can have some of these symptoms in the short term, and severe dehydration and other conditions can lead to that as well. But also sort of the absence of overt causes, not curses, of sinus tachycardia and dietary influences, etc. So we're really excluding other conditions that may contribute towards it, and even other thyroid conditions, for example. So we look at a really thorough history when we come to these patients because they often have a lot of comorbidities. So that's a thorough medical history to exclude those other conditions. A physical examination to look at joint hypermobility because we see an increased prevalence in this population as well. And Jackie will probably talk about this a little bit later, but that's because the arteries and veins are a little bit more stretchy, or it's postulated that they are. So they don't struggle to regulate blood pressure. The Baton's hypermobility test is a very important one. So if you just Google that, that's fine. But one of the measures is basically bringing your thumb to your forearm. So I'm just trying to get the white background. You can see that I can't touch it, and Jackie might demonstrate the other way. So she can get it to her forearm. So it's both thumbs or a little finger goes back, and I'm as stiff as a board, yet Jackie can pop it all the way back. She can. And then there's the elbows, which can hyperextend, knees, and touching palms to the ground. Now, touching palms to the ground, we need to be a little bit careful because if they have low back tightness, then you might not get a positive with that. But if there's 4 or more points, that person is considered to be hypermobile. Now, hypermobility does not always mean that you have orthostatic intolerance or POTS. It just means you're a little bit bendy. We look at blood pressures and heart rates, as I mentioned before, to make sure that the blood work is there, and sometimes a head-up tilt table test as well. But we don't do that within clinic. So as you can see, there are a heap of symptoms that come with this. Now, I might go through a couple of these, but would love some interaction if anyone would like to know, why does that one happen? So I've discussed the lightheadedness and the visual disturbance. Nausea and vomiting is quite an interesting one. So often people have a lack of appetite and nausea, and we often see a few comorbid eating disorders that can be with this as well. And this is primarily because when the body is struggling to regulate blood pressure, it produces adrenaline as a vasoconstrictor. So that constricts the blood vessels, also can lead to some tachycardia, but as a result, blood moves away from the organs. So we don't digest the food as much. So this is where we talk a lot with our patients and our dietitian in regards to foods that are easy to digest, as well as not eating around exercise and other activity. And if we think about, often say in general in the hot weather, even for a person without this condition, we don't tend to have the appetite. It's just much more within these populations. Anxiety, I think, is probably one of the other ones that's actually really important to mention. As I mentioned, that we get that adrenaline as a vasoconstrictor. So as a consequence of that, people will actually feel quite anxious and can present as that as well. And often we see a misdiagnosis in this population as just saying, you're just anxious, because they are displaying all the symptoms of anxiety, but they're not worried. And we have educated a lot of people, especially with psychologists, that are seeing them, because if they're sitting still with their feet down for an extended period of time, in the latter half of a session, they're starting to look anxious. And the psychologist goes, well, you're fidgety, you know, you're a bit absent-minded, you know, you're getting a bit irritable. And again, the standard signs or some of the signs of anxiety, but it's not because of they're worried or they're not comfortable. It's purely because of that blood pressure management. Fidgety is when we activate our muscle pumps, then we'll actually help pump blood around. And people will tend to move towards salty foods as well, because salt helps us retain fluid, and the more blood volume we have, the better that is as well. So a lot of people normalize a lot of these symptoms, especially if you are hypermobile over your life. You go, well, doesn't everyone go blind when they stand up? And it's usually me going, Hell no. And often with this, we'll actually see people that, because we see a lot more women, so 80% women with hypermobility, and generally a younger age. So I'll often have, say, a young girl, maybe 14 to 16 years of age, with a mother and father. And I say, when you stand up, do you go blind or do you have tunnel vision? And usually the daughter and the mother go, yeah. And the father's going, what the hell are you talking about? And they go, isn't that normal? So I think that when we go through these symptoms, especially if people do have hypermobility over a period of time, it's really important to actually say, do you have these symptoms? Are you normalizing them? Because they're not normal to me. I don't get dizzy when I stand up, unless I'm severely dehydrated. I don't see little silver stars, except for the same reason. So I think it's important to normalize that, or to see if the person is normalizing it, so that we actually get a really true indication of the impact of these symptoms and how the impact and how it's going for that person.
And this is where, unfortunately, a lot of our patients, I think the average average amount of time for diagnosis for POTS in particular is 10 physicians and 6 years. And the amount of cases that we have seen where they have being given some sort of psychiatric diagnosis is phenomenal. And once we explain to our patients, it's the same physiology, that fight or flight mechanism that is, controlling, trying to increase so vessel constriction, increasing the heart rate to move blood towards the head so they don't faint, and how that mimics anxiety. A patient understanding that can change their whole outlook, because they get anxious about being anxious when they know they're not anxious, and that just perpetuates that cycle. And when we're really looking at it, I mean, you can just see from how many dot points there are on this page of how we, and why it might get missed from, a GP, that not putting all of these other symptoms together and going, okay, this isn't just anxiety. So it's a really good thing to be able to go through and look for these other signs and symptoms that, don't really fit with anxiety, and that is more around this OI and POTS presentation.
Definitely. And I think especially with the presentations that we're having within clinic, people don't realize something is a problem until it limits their life, and they do normalize these symptoms. And if it isn't limiting them, that's fine. They can move on with life. But for health professionals, that are on today's call, thinking about presentations for people that have joint pain, are they hypermobile? Have they had subluxations, dislocations? And then it's really important to look at those other symptoms. Do you have these? To do the blood pressure test, which is relatively easy to do, because I think a lot of the time there's trigger events that can lead to a sensitization and the volume increasing in the person's symptoms overall. So the triggers for these people is a lot of upright posture. So again, like I was talking before about blood flow, you don't see waterfalls going up, they only go down. So remembering that change in position, and even sitting for too long, they'll become fidgety. So a lot of students and exams and these type of things, they can lose concentration towards the end. And showering is one of the big ones as well, because often you're standing still in a hot environment. So the heat. So because when it's hot, we naturally have to dilate our blood vessels to cool ourselves down, which then means that we have increased blood flow demand. So the more pipes that are open, then the less volume there is. So we struggle to regulate that blood pressure. Stress or anxiety can also perpetuate this too. As I mentioned before with eating, that if we do a lot more activity, we struggle to regulate the blood to our gut, as well to the activity or in hot weather. Dehydration. So if we have less volume in our blood vessels, then it's harder to constrict, so therefore harder to regulate blood pressure. Prolonged recumbencies is often people feel very comfortable lying down because they feel better, but the more that we do that, it actually leads to a form of deconditioning. And we should be encouraging where people tolerate is for our patients and people with these conditions to have their feet on the floor all the time, because that is challenging the blood flow and is one of the forms of fitness. alcohol is a really interesting one. And this is because alcohol is a vasodilator. And classically, people with these conditions don't get alcohol. They'll have a drink and then they'll go, I feel a bit sick and a bit dizzy. I don't get this. Why would anyone want to do this? Yeah, so I think, again, that's a really great clue. And with menstruation, there can be blood loss, but then also hormonal changes that can lead to changes in elasticity as well. So I'm actually going to tell a quick story about someone that I treated a long time ago that pretty much brings these together. So as a young woman, around the age of 19, she went to the pub with her boyfriend on a relatively hot night, had some alcohol, got into an argument with her boyfriend, ate a kebab, as you do, leaving, then decided to walk home on a hot night. So, and was dehydrated as a result of the alcohol. She actually woke up in emergency and said, what happened? And said, well, someone found you on a nature stream. Now, this is an extreme sort of case that goes with this, but shows, you know, when you bring these things together, that you can start to go through people's history and going, that doesn't make sense. And especially when you explain these symptoms, often there can be a genetic component. So you'll go through people's family and they go, who else in the family just hates summer? You know, and they're like, grandma, she always complains about summer. She loves the winter. Oh yeah, she's a one pot screamer. No, she doesn't touch alcohol. She's always fidgety. She loves salty things. Yeah, so there's these patterns. And again, through good histories, we can actually start to pick that up and make better judgments and help out this population. So we'll go to the next slide. Okay, so this is where I'm going to hand over to Jackie a little bit here, and she'll take over for a bit.
So I guess the reason why we chose OI and POTS and EDS and HSD is because we generally see majority of the time these conditions go hand in hand together. So EDS is a group of connective tissue disorders that can be inherited. They vary in how they affect the body, which I'll go through in a little bit more detail in a moment. So characterised by joint hypermobility, then we've got skin hyperextensibility, so people can kind of pull the skin, you know, away on their neck. The backs of their hands are quite extensible, and tissue fragility. So this is where people will find that their skin reacts to things like band-aids, or if they've got sports tape and it just tends to tear the skin off, or brushing up against, you know, you accidentally bump into the door and it's not just a bit of a bruise and you walk away, it actually tears the skin. So there's that real tissue fragility. So it can cause symptoms throughout the entire body. And this is one of the most things that we see that is really difficult in terms of diagnosis and management, because there's so many things going on. And with our patient population, you know, they might be seeing a GP, a cardiologist, an endocrinologist, a gastroenterologist. They've got so many people involved in their care because it causes so many symptoms throughout the body. So in terms of EDS, so Ehlers-Danlos syndrome, there are 13 different types, okay? So in 2017, so they redone all of the different subtypes, and we don't use the language of, you know, type 1, type 2, type 3 anymore. We're using classical-like, cardiac, vascular, hypermobile, etc. So there are 13 different types. And unfortunately, one of the most common types that we see is the hypermobile EDS, and it is the only one that we cannot test for genetically. So unfortunately, to get to the diagnosis of the hypermobile EDS, it's ruling out all of the other 12 types before coming down to this. So, but again, it is the most common one that we see. In terms of hypermobility spectrum disorder, so HSD, so a relatively new term that is being used. So this is a group of conditions involving joint hypermobility. So as I said, it's diagnosed after all other conditions have been ruled out, including all of the EDS types. And with the joint hypermobility, so it can be localized. So some people can be hypermobile in just say their elbows or just their knees, or they can have like all of the 9 on the Baton scale, or it can affect all joints. What I've recently learned as well, just doing some additional professional development, is that some people can be stiff hypermobile as well. So for me in particular, I meet everything on the Baton scale apart from the elbows. I don't have super bendy elbows, but my shoulders and my hips are also extremely hypermobile as well. But I am really stiff through my thoracic spine. So I would be, you know, still classified as hypermobile technically, but I am stiff in particular areas. So we've got to take into consideration is just because people may report, oh, but I'm stiff here and I'm stiff here, but if they're hypermobile in other areas and they've had, you know, lots of injuries, then we would really be looking at that they do fit that hypermobility spectrum. So the HSD ranges from joint hypermobility with no other symptoms. So they may not have OI, POTS, fatigue, the gut disturbance or anything like that. So if I look at my mum and dad and my brothers, well, I'm the only one that really presents with particular problems. You know, just because the others don't have any of the other symptoms doesn't mean that they don't fit hypermobility. So, you know, we've got to look at that some people are actually quite fine just being bendy. And then there are others who have quite complex hypermobility spectrum disorders that can be life-threatening. So quite and have the life-altering symptoms that very similar to the hypermobile EDS. Sorry, my clicker's not working. So the types of hypermobility spectrum disorders, so as you can see there are, so the global joint, generalized joint hypermobility, peripheral. So what we can often see is that people are hypermobile in mainly just their hands and feet. And then there's localized. So it's showing us here, you know, where we might see them on the Baton score and what musculoskeletal involvement there is. So just joint hypermobility in fewer than 5 joints is referred to as the localized joint hypermobility. Hypermobility in 5 or more is what is classified as generalized joint hypermobility. And as I mentioned, peripheral affects hands and or feet only. And then there is historical joint hypermobility, which is found in older adults. So really interesting when I see women in their 40s and 50s coming into the clinic with chronic pain conditions. It is really important that we go through their history as children. So were they gymnasts, dancers, swimmers, you know, highly physically active, singers as well? Because what's happened across time is as our tissues change, arthritis and just aging in particular, you won't see, you know, we'll get them to do the Baton and they're like, no, there's no way I can touch my thumb to my forearm or touch the ground, not a chance in hell. But they have been hypermobile in their younger lives. So we've really got to consider, well, what has led to their chronic pain, you know, later in life? And it's most likely due to the pain sensitization of hypermobility across their life, where they have decreased their physical activity and more become that real stiff and sore. So it's really important not to miss that in a way, that we're not treating them as a chronic pain in terms of joint damage in regards to the brain interpreting threat of too much joint movement over time.
Before we move on, Jackie, there's a question from Heather in regards to the stiff hypermobile. Yep. Do you think this is because those areas haven't needed to move as the other areas have such range?
So I guess we can see that, so it's quite common that we will see the stiff hypermobile, so through the thoracic spine in particular, and also some people report that they can be a little bit stiff in their hips. So why we see, I guess, a bit of stiffness through the thoracic spine is because there is more movement through shoulder girdle, through lower back and hips. So there needs to be a certain pivot point and stability, and the thoracic spine unfortunately bears a lot of that brunt. So yes, we do see that they haven't needed to move as much. We can become, and I guess thoracic spine, you know, it's not something that we will move through a lot. We will use maybe lumbar spine a little bit more, or we're overusing like shoulder and reaching for those particular areas. So yes.
Thanks, Heather.
Thanks, Heather. Skipping forward. So connective tissue disorders. So disrupt the fundamental processes and structures of the strength. So this involves tendons, ligaments, and as Nathan's been talking about with OI and POTS, is that blood vessel elasticity. So this is where we do see underlying and, you know, we could say predominant diagnosis being around EDS or HSD, and then OI and POTS being as a result of that as well, because there just isn't the amount of contractility in the vessels to return blood flow to the trunk and to the head. So we're just not getting great blood flow, and that's why we get discoloration. So we often see that blotchy purple looking in the legs in particular. So we're not getting fresh blood flow return to the heart and lungs to be reoxygenated. We get that real mottled look to the skin, and why our hands are often cold as well. You know, we're not getting that good venous return. So that passing of oxygen, passing of nutrients through the capillaries, and as Nathan mentioned before, you know, that blood flow return to retina and cornea. So we get a lot of those visual disturbances. So I've always been worried I get these floaters in my vision, and I also always thought, you know, I was swatting bugs away and things that were never going to go away. So, you know, when I look back across my life and knowing what I know now, it all makes sense, and it wasn't really normal when I was just tried to normalize a lot of it. So, yeah, widespread problems of different severities depending on, you know, where the most problematic things are happening. So what I want to go through now is in terms of exercise precautions. So obviously pain is a big thing in particular for the EDS and HSD population, and being able to really explain to patients around that pain doesn't equal damage, and we've got to be looking at, I guess, and we love explaining this in the from, you know, David Butler and Lorimer Mosley is so DIMS and the brain identifying threat. So if we think about, well, yeah, it's definitely not safe for our joints to move excessively within their capsule or move too far away. So we really want to be making sure that we're exercising within safe ranges of movement. We've got to be cautious of subluxation and dislocations. So I'll talk about it in a minute in terms of, well, where do we start with prescription, and it'll be specifically around those two things, bruising and fragile skin. And this is in regards to, so if you're using particular equipment, so whether they're holding on to TheraBands or you're looping TheraBand around like the thighs or around arms, we've got to think about fragile skin. So are we going to tear that? Fatigue. So I'll talk about the prescription to manage fatigue in a moment. Reduced concentration and cognitive dysfunction, making sure that you're using particular, so PhysiTrack, for example, or you're using some sort of program that has pictures and or videos and really good descriptions, because your patients are definitely not going to remember what you're saying. So we really need to make sure that we're writing everything down for them, making sure they understand, get them to repeat what they understood that you have said, because with fatigue and what we explain to our patients in terms of that sympathetic nervous system being in overdrive, that actually it turns off the prefrontal cortex. So the thinking part of the brain shuts down, it goes offline. If anybody's ever watched Dan Siegel's YouTube clip about the brain functioning and how we flip our lid, because we don't need to think to survive. The dizziness and lightheadedness, and this is where I'll combine that in with OI and POTS. So we do not want to be going from a lying down exercise to then standing up and then lying back down and then getting up. we want to either start with your upright exercises and finish lying down, or the other way around. We definitely don't want to be changing positions too much. So MCAS being mast cell disorders, so people that have a lot of allergies. So it can affect the airways and also the skin. So just being careful with particular, so the TheraBands, are they the non-allergy type ones? So being cautious of that. Vascular EDS, so aortic dissection is one of the huge risks with vascular EDS. So we want to be really careful with exercise intensity, Valsalva maneuver, and all of those types of bearing down activities and breath holding with vascular EDS. And that feeds into blood pressure and heart rate management. So because of the high sympathetic load on the nervous system, somebody just performing some bicep curls, and because arm movements very close to the heart rate could shoot up really quickly and contribute to perpetuating their symptoms, excessive fatigue, dizziness. So we really want to make sure that we're pacing their exercises really well and monitoring that hemodynamic stability. Poor proprioception, balance and spatial awareness. So a lot of these patients will report how often they will just bump into door frames, knock their leg on the edge of the bed, different things like that. So there is, that reduced spatial awareness with all of these patients. Sweating too much or too little. So we've really got to be mindful of body temperature. So making sure that the exercise space is not too hot, not too cold, because unfortunately the thermostat within our bodies, it's like 1 minute we'll be cold and we've got 10 layers of clothing on to try and warm up, and then all of a sudden we're trying to take all of these layers of clothing off. So just monitoring that. And obviously headaches and migraines, reduced blood flow can be due to tension, neck dysfunction. So just being really mindful about, headaches, dizziness and migraine. Okay, so I know that list looks really scary in terms of things to be cautious of with prescribing exercise, but once you get used to working with this population, these things just come naturally. And lastly, I just want to go over some particular guidelines. So your programs definitely need to be individualized. So no patient that we see, even though they may have the same diagnosis, they are all different. And what we really need to focus on is starting to teach this population how to breathe first is the most important. So what we find is, because of the way that sympathetic nervous system is on, it's in overdrive, we're all these upward breathers, we're all really tight. They don't know how to breathe down into their diaphragm. We want to try and increase vagal tone, parasympathetic activity. And what teaching this population to do with breathing, you're actually putting them back in tune with their body. Can they feel where tension is? Where are they holding tension in their muscles? How are they holding their joints? Because over a period of time, if we've been experiencing pain, subluxations, dislocations, well, what are we going to do to protect? So starting off with just evaluating their breathing, teaching them how to breathe properly is huge. From then, we then move into proprioception. So do they actually know where their joint is in space? So majority of hypermobile people, their stability and their strength is only when they're locked out on their joints and they're feeling really strong. What's happening there is they're not actually using their muscles at all. So when you observe a hypermobile person move, you will see that they just lock out on their joints all of the time, and that's the only way they know, oh, that's the end. I was working with a little 10-year-old a couple of years ago, and when he needed to get close down to the floor, he would just fully lock down, full squat on those knees. It used to make me cringe a little bit. So we really need to teach these patients how to know where their joints are in space. So this can be as simple as I sometimes stick dots on the wall and I get them to stand in front of them and reach to the dots. So teaching them that end of range is not safe. We need to use those proprioceptors within the joint. We need to use those muscles to control the joint. So you're watching them to reach that they're not going to full end of range of where they're working to, okay? And that's going to take a lot of cognitive work for them as well. So even though you're literally just teaching them to reach, you know, squats, sit to stands, those types of functional movements, like picking up the kettle and pouring themselves a cup of tea, that will contribute to fatigue. So as simple as the exercises may seem, and they're like, these are really boring exercises, I'm not working up a sweat or anything. It is imperative that they have that proprioception, which then feeds into balance and that neuromuscular education. So it's all about that joint stability and control, because without that, we can't go loading them, because we're only going to cause further joint and muscle damage. Okay? So once we've addressed that joint instability and that's no longer a limitation, that's when we're optimizing its function. We can start to work on strength and fitness. So we either want to start with so no resistance, moving into some gentle resistance with closed kinetic chain, or what we call pseudo closed kinetic chain. So that could be such as a TheraBand around the thighs, or you could place a TheraBand around the forearms to do some. So we're trying to shorten that lever length as well, okay? So the pseudo closed kinetic chain, so you can use bands, yoga blocks, the suspension trainers, etc. We do want to start with lying down, so the majority of their body is in contact with the floor, and then we're slowly reducing how much exposure they have to that feedback. The isometric, from a pain point of view, like it has that analgesic effect. So depending on how limiting pain is, and we're just improving muscle activation. What majority of people with hypermobility will do as well is when we get them to contract, it's kind of that all or nothing. So there's a real, you know, lockout and spasm to find stability. There's no gradual on and off, and that's where we want to teach them that through exercise as well. So we don't want any increase in pain. So we're not ideally going to take away pain, but we definitely don't want to increase it. If their pain stays the same, then that's a good measurement. Slow, low, and controlled. And that's at the prescription that we should have. Generally, my prescription for this population is maybe 1 to 2 sets of 5 repetitions. And we want them to be able to be really good and really solid with that before we would look at progressing into faster, larger, and multi-directional. Monitor breath holding, you're going to have to teach them how to move and breathe at the same time. And as soon as you start to introduce movement, you may see them going back to breath holding. So there's so much education and feedback that goes into this population. Do they wear compression wear? So compression leggings, and we want that medical grade compression. And that can help with blood flow. It can also help with pain, but also that biofeedback and making sure that they're remaining really well hydrated during the sessions. So hopefully, I mean, like Nathan said, we could talk about these populations for hours and hours and hours, and we usually do. But hopefully that's given you some base understanding. So we would really just love you to throw some particular questions. Before I open that up for questions, there's some questions we were emailed through that I want to address. So about locking out on knees and elbows. So as I mentioned, it's just natural what we do. I was actually taught how to not lock out on my knees last year, going through some specific rehabilitation. And what we actually need to find is, so getting somebody in standing. So I'm just actually going to stand up, not that you'll be able to see my entire body. But what we actually need to teach people is, so when we lock out on our knees, our pelvis automatically shunt forwards. Yes.
What we might do is we actually might, because we can make, because I think people can see the presentation at the moment, we might just go to the next one, the next screen, which has got a few of our contact details if people want to ask questions later. Then we might finish the talk and that'll make us in a larger screen, and it'll be much easier to see.
Yeah, sure.
So this is some of our contact details. There's the website. We are happy to take questions for people via email, etc., assessment, etc. We just really want to make sure that these people are managed a lot better. So there's a Facebook, as well as we've got closed groups. We actually have just launched a YouTube channel as well, and this will be posted up to that later. But please follow through with those materials, and don't be afraid to reach out. We love talking to other health professionals involved in this area.
And I'll just go back to, the exercise guidelines for Heather. So is that the one there, Heather? I can, if you want to screenshot that page, but we will upload this, as Nathan just mentioned, to our YouTube channel. And then that was that second one on the exercise guidelines from there.
Yeah. We'll publish this as well, Heather. And if you do want a copy of the presentation, then just send us an email, and we will be more than happy to send that out to you as well.
So I just want to go through this one quick explanation. So hopefully everyone might be able to see me. You won't be able to see my whole body, unfortunately. But focusing on the pelvis is a really good place to start. So when we lock out on our knees, obviously you can't see my knees, but my knees bend back quite a way. We will sway through the lower back, and then we round through the shoulders and the head pokes forward. Very typical postural presentation for this population. What we actually want to do is, rather than teaching people to unlock their knees, so what we actually do is, we want them to soften their knees to find where neutral is. So just getting them to rock their knees backwards and forwards a bit and find that soft neutral position from there. And then what we're teaching them, in front of a mirror, hands on top of that iliac crest, and actually get them to shift their weight directly backwards. So we're sliding across like this, so the weight moving back onto the heels. And like, I don't know how many times I nearly fell over doing this, but what we're doing is that we're shifting the weight backwards, we're getting better activation of these glutes, we're turning off all of the quads that want to lock on all of the time. So we're very quad dominant, and we want to activate these glutes a bit more. So we're getting patients to work through. So we want to unlock those knees, soften those knees, sliding back to feel where those quads are unlocking, those glutes are turned on and working, and holding that posture, and then coming off and relaxing. So this is how gentle and specific this exercise prescription needs to be to begin with. And, we do a lot of that education around, similarly with the neck. A lot of people, if you're giving them a rope to help with upper body strength, the first thing they're going to do is this. We really need to educate them about, okay, we're doing this exercise, but where is our awareness in terms of our chin, our neck? We're not overusing and contracting through those pecs. So we've got to work with the whole kinetic chain. And this is where, we tend to work through a lot of the slings as well. So just because someone's got, left shoulder pain, well, it could be the fact that, their right glute, is one of the most problematic things. So we've very much got to work through, anterior and posterior chains and things for this population as well.
And I think adding to that as well, Jackie, coat hanger pain is a very common pain with this population for all those reasons that you described, and that sympathetic load. And so I suppose it's another one for people to look out. And if you imagine, if you put a coat hanger in your shirt, the back, it's sort of the neck and around this area. So I think that really fits well within what you've just mentioned. Go ahead, Jackie.
Does anyone have any other specific questions that they'd like to ask, whether that's about OI, POTS, EDS, HSD, exercise prescription? So just throw your questions at us about anything.
Great. And yeah, please do take advantage of this time with us. So we've got one from Maggie. So what causes people with these conditions to excessively sweat without physical exertion? So I think when we look at sweating, it's the body wanting to cool itself down. And if you look at primarily this condition, what is it, the foremost part of it? And that's regulation of blood pressure. So this can be sometimes an overreaction or even an underreaction. Some people don't sweat at appropriate times or don't sweat enough, and some people sweat too much. So when the body does not regulate its blood pressure, then that can lead to increased sweating. I'd probably put that as the simplest way of explaining it. Does that make sense? Would you add anything else to that, Jackie?
Yeah, I I'm just going to share my screen again. So this is a particular handout that I will show patients because, so where we're looking at, this fight or flight response, it's on all of the time. It's trying to regulate the heart rate, the blood pressure. We've got to think about that fight or flight. The brain is detecting that there is threat, whether that is through the internal organs, whether that is external in the environment. So we've got to think about, well, what does this adrenaline, what is this adrenaline doing to this person? And we think about all, and I show this to patients, is we look at all of the physiological changes that happen, and it's where the body is getting ready to fight or flight. So if you're thinking about these adrenaline surges that just tend to be going off in this person's body all of the time, and hence why they get so fatigued, and where adrenaline sensitizes pain pathways. So this is a really good example of a diagram that I show people, and why that, within a split second, somebody can be really sweating up when they've just been freezing cold, because something either internally or externally has triggered that response.
Yep, perfect. I love this question, and I was hoping it would come up. Can someone with orthostatic intolerance do standing exercises if they are not symptomatic at the time, or do a couple of reps and stop when symptoms develop? So I think to start with this, we've got to really look, are symptoms dangerous? And the thing is, no. I think the symptoms are the body telling you, I would like you to change. Like I mentioned before, someone might think, oh, I'm not getting enough blood to my head, that's why I'm getting dizzy. And that's why I deliberately said that, is because no, that's not the case. Otherwise you get brain damage. So I think with these symptoms, whether it be a little bit of lightheadedness, whether it be a little bit fidgety or sweaty, that's okay. I think it's more about the education with that. And someone might say, oh, but my heart's going really fast. And it's more like, well, good. I want that to go fast, because that's your body actually responding and working with it. So I think it's a duty of care for us to actually talk about symptoms. And as far as, is it safe for people to do exercises upright? 100%. Like, I think as long as they're not feeling worse later on, so it doesn't limit their activities of daily living or increase pain. Feeling a bit of pain during, that's okay. Again, that's a warning sign, and how we interpret that. And that's us as a therapist to help them in that journey. But I think a lot of the time people have said you must start with swimming or recumbent exercises. Not necessarily. I think it's what they're actually engaging with and what they can do. And if anything, like with any exercise prescription, we want to be challenging them so that their body adapts. We've got to remember, we can't fix hypermobility. We can't make them stiff, but we can support that system and enhance that person's ability to regulate blood pressure. And that's going to be putting as much stress on them as they tolerate, so they don't break. So I think that when someone says you've got to start with recumbent or water exercises, it's actually no, I disagree with that. For some people that might not be able to tolerate it, 100%, or within safe ranges. But for the most part, we need to be challenging them in the best way possible.
Yeah. And like we say, it's very individualized. Like if this person can, they're upright most of their day, or they're sitting at their desk at work, then there's no reason why you need to take them down to lying to begin with. We're trying to increase bodies, so we're getting the body to adapt and tolerate that orthostatic stress that we're putting it through. Whereas if you're starting off with say somebody that's been bed bound, well, you'll start them off lying, and then you'll bring them up slightly with some pillows or on a wedge on a reformer or something like that. Then you'll bring them to sitting exercises with their legs out, then you'll get them sitting legs down, then you'll do some standing, etc., etc. So it's just that we think about that gradual graded exposure. And just about I love the question around symptoms as well. And for anyone, again, I'm going to refer back to David Butler and Laura Mosley in the DIMS and SIMS. And we often put, the likes of dizziness, palpitations, like they're a dim, like why would you want to experience them? But then we also have them on the side of SIMS, because if you didn't get dizzy, then you're likely going to faint, aren't you? If we didn't experience pain, well, we're not going to pull our hand away from the hot plate and we're going to burn ourselves. but what's really important to explain to patients as well is, unfortunately, just the volume at the moment is turned up. Your body's a little bit, it's a bit oversensitive. So it's reacting to, you know, the garbage truck that drives by out the front, you know, it detects that that's a really loud noise, heart rate goes up. We're like, well, yep, the garbage truck's not very dangerous. So what we're doing is we've got to slowly just work on turning the volume down over time so that the body is not as reactive to internal or external stimulus. So 100% we want to say, we want to hear about your symptoms. You know, we've got to normalize your symptoms because, you know, they're going to be there. They're, you know, and like Nathan said, we can't change hypermobility. We can't change our genetics. You know, it's about listening to the body and go, oh, I got dizzy. Oh, I stood up too fast. My bad. And being able to move on rather than go, oh my gosh, I've been dizzy. Now I have to lie down for the whole day. So there's a lot of education that comes around that.
And we had a quote from one of our patients the other day that they called themselves medically fascinating. And I thought it was a really great way of looking at these conditions. There's not wrong nor right, just medically fascinating. They're complex, but that's why they're enjoyable. Which probably just moves into the next question of saying, what do you think is the most effective treatment or treatments? And what we're just saying there as well, there's lots of things. I think education is key. I think that there's medications, and we haven't touched on today. If someone, there's vasoconstrictors, ones that increase blood volume. There's conservative things like salts and water and compression. Obviously, there's the exercise. The cardiovascular is extremely important because that's about blood pressure regulation, but then also strength is important in regards to legs and increasing the size of those so they can act as muscle pumps, but then also the proprioception. So I think it's about getting each individual patient and saying, well, where would you like to go? You know, what is your goals, and make sure that it's patient-centered. So is that to play with their daughter and to actually pick them up in a safe way? You know, or is that to get back to sport? Because we see some elite athletes with this, some really amazing swimmers, and even I've had some AFL players. So I think it's more about education and to meet their individual goals, but a combination of the conservative management being the education, then there's a medical management, then the different forms of exercise. Another one, any guidelines for children and performing strengthening exercises? So I'll let you cover this one. We covered a bit, remember Tristan, which we were talking about before.
Yeah. So I guess with children and hypermobility, it's so making it game-like for them. So when I was working with this 10-year-old, I mean, educating him, you know, through using, you know, squats and rows and different things like that, he just wasn't interested. So I made it game-like. So I used to stick so dots on the wall, and I would have numbers in them. And so we would do maths. Like I would say, okay, well, show me which ones add up to 22. And he would point to, you know, so we would combine a little bit of learning because he was taking a lot of time out of school. So it was really thinking outside the square in that way of going, well, I need to help him with understanding where his joints are in space, his balance, his proprioception, but how do I make it interesting for him? So really getting to know him as a child, speaking to his mum and dad about, you know, his interests, and I would often include a bit of that. So we would do like some soccer kicking in and out. So looking at his ability to change direction, his joint positioning, risk of sprains and strains. Like we do some crawling on the floor, rolling. What else would we do? Like throwing and catching a ball using tennis rackets. So I really went back to, and I actually borrowed a book off my sister-in-law who was a primary school teacher. So primary school PE book for the games, and then I applied my knowledge of proprioception, balance, joint stability, breathing, and a bit of education for him. So, I mean, it's the same guidelines for children and adults because the goal would be the same. I guess one main difference that we may look at in terms of, so females who are going through puberty where ligament laxity because of hormone changes may put them at more risk. And we've got to really think about protecting the joint. So only exercises with a stable base. So lunges, not really a great thing to start with. So we want to always have like feet side by side type exercises as well. So yeah, hopefully that helps and answers that question.
Yeah, and look, I think the number one thing, and I think whether it be adult or adolescent or child, is functional exercises that are going to help them with their activities of daily living, whether it be school or like another young boy that we see, Nate, who's about football and, you know, how to get the most out and how to play and recover and work with that. So I think it's very much individual, but there's the general guidelines you would with any population. It's just taking the other factors of this condition into account. Esme is asking, do you use VAS and symptoms report as the main indicator for progression, or more like blood pressure, heart rate, objective data? A really interesting one. I think there's that real challenge, I think, as exercise physiologists being researchers and practitioners. And with the researcher side of me, I love outcome measures. We do give a lot of questionnaires out with the patients that we have around fatigue, pain, anxiety, depression, and pain self-efficacy. But the number one thing in the outcome measure is the patient themselves, what they're achieving and what they're doing and reporting. I think that if we go back, and maybe a classic example, I've seen a young boy with a blood pressure, it was 80 on 50. And he stood up and it went down to, I think, 70 on 40. And I've gone, are you okay? He's gone, I'm fine. Now, they had no symptoms. So I think that we've got to be very careful. And like with hypermobility, they can bend the other way and there's no pain. So I think within these populations, I think we like clinical and global improvement scales, you know, the general questionnaires are great. But at the end of the day, with our reports back to doctors, it's more about now they've been able to return to school. Now they've been able to play sport. They haven't been injured. That's more what we work with, because a lot of that objective data really varies for each individual. I think it can be good to refer back to a measure and for that individual, but across that population, and probably more speaking as practitioners rather than researchers, that's not an area we spend a lot of time on. It's more about their function.
It's comparing them to, you know, well, when we first saw them, they were doing this, 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 and this. And now 6 months on, they're able to achieve this, this, and this. So, and I guess talking about their symptom improvement, or, you know, the symptom severity has now decreased. You know, they're less fear avoidant because of the dizziness and the tachycardia. So, and it's hard using BP and heart rate as well, because I mean, a lot of these patients might be on beta blockers. So, you know, we can't always rely on, you know, heart rate, blood pressure and things like that, because the medications are not going to tell us. So we might use like a Borg scale or shortness of breath scale, just in terms of that perceived. So we're more about that subjective than looking at too much objective data. Yeah,
and look, we're about to start some research into heart rate variability. So even though we're practitioners, we're involved with La Trobe Uni and some of the master's students. So we've done one study into compression, but then we are looking at heart rate variability specifically within orthostatic intolerance and chronic fatigue syndrome, and there's very little data. We do know that it's decreased within these populations and correlates directly with cognitive dysfunction and unrefreshing sleep, which is part of that brain sort of work by Siddell. But I think that, yeah, it's something we're always looking for, but I think there's so much variation within them that from day to day, and using it as a measure for people to go back and say, well, my heart rate's this, or my heart rate variability is this, I think takes away from them actually listening to their symptoms and their body. And truly that's the best indicator of what we're doing and how we're going. So one of the last questions is, what's the prognosis of recovery like?
Wow, it's a question that we get asked a lot, don't we, Nathan? But I mean, it comes back to being individualized, and I think from somebody who has, and I'll speak from a personal point of view, you know, lives with the condition, has actually done the Active Health Clinic program of what we do. I think it comes down to, and this is where I'm again talking personally, is, you know, the effort that we put into implementing the tools and strategies, you know, giving it a go, being educated, acceptance, you know, all those types of things I think can really shape the way somebody's recovery goes. There are a lot of uncontrollable factors like we talk about, like we can't change genetics, we can't change hypermobility. You know, we can improve symptoms, we can't take them away. So it is definitely about management. And I mean, I'm a strong believer in that I can help people manage their health better and have a better understanding and improve their quality of life and their function through education and movement. So Nathan, I mean, you'll probably have a bit more to add to that.
Yeah, look, I agree with all those, and I think it's some people, they can get rid of some symptoms completely, and have others that I think, like the classic one I often say to the adolescents when I see them, and usually with their parents, that you're never going to be a big drinker, you're never going to get alcohol, you're always going to be a lightweight, and you can't change it. Now they can train, they can get better at it, they can drink more. I've seen it happen. But that's just the fact of it, and we have to live our lives in a different way. And I suppose if you look at someone like a diabetic, that, you know, they can be asymptomatic if they manage their diabetes really well. And I think you could look at the same thing with blood pressures, but some people need medical support. You know, some people can manage it conservatively. Again, the type of diabetes, type 1 or type 2, you know, makes a large change for that as well. So I think that when you're coming, and often what I say with the individuals is, we know that we can improve from here. When we know that we can teach you so much about this, you can understand it, you can better manage this, we can build you up. But I don't know where that glass ceiling is. Everyone has that ceiling, otherwise we'd all run like Usain Bolt and break world records. We all have that handicap to a point. So I think it's about saying, look, let's work as hard as we can. If we hit a glass ceiling, let's see if we can get around it. Let's see if we can work around it. But it might be that that's the point we can get to. But again, it depends whether they're sensitized, whether they've got fatigue syndromes, whether it's straight out OI POTS, whether they've got hypermobility, whether they've got a mast cell disorder, whether they've got food sensitivities, and I can keep going on with that list as well. And that's what I think makes it magnificent and really magical to work with these populations, because I think when we get to that dead end, which sometimes we do, and we go, I think this is where we're at, and there can be some genetic conditions, but this is where we reach out through our networks, and we'd encourage all of you, and it's great that everyone is on this call today and this webinar. If you're unsure, then reach out to us as part of the team. We will spend some time. You know, we're fortunate enough to have 10 practitioners now, so we can take out some time and to answer those questions. So please always do reach out. Okay, well, I think we've covered all the questions, and we've gone a little bit over time, but I don't think we have a time schedule, to be honest. So thank you for everyone that's been involved today. We really do appreciate all the questions, and hopefully that's been helpful. We set a goal of impacting 1 million people by 2022, and this is only a small part of that. I think we're about 380,000 people in, which is exciting. So again, thank you for this. If you found it helpful, we'd love you to share it around. We will pop it up on the YouTube. We'll pop some links into the different ESSA pages, etc. And if you want copies of any of the handouts or the talks today, then again, please just email us. We're always more than happy to share. So a big thank you to Jackie as well for sharing. Yeah, we really enjoy talking about this. Okay. Excellent.
Thanks, everyone.
Thank you. We'll finish up there.
Yep.